subscribe now and press the bell icon. Never miss an update.
Welcome to Health Live at Seniors Today. Depending on which part of the country you are in, it's perhaps raining or there could well be a huge downpour in some parts of the country, especially in Mumbai. So stay safe, everyone, and thank you for being here. Today we've moved from Hyderabad to Pune, and we have in the house Dr. Nayantara Das, who's a specialist in emergency medicine. Before I greet her, I will introduce her. Dr. Das is an ER physician currently practicing at the Manipal Hospital in Pune. Having completed her postgraduate training in the field of emergency medicine, she has managed the ER of several multi-speciality hospitals in Bengaluru and Pune over the last few years. She specializes in all medical and surgical related emergencies with a special interest in the management of trauma and pediatric emergencies. We've invited her to speak on common illnesses in seniors and when to consult a specialist. Welcome to Health Live at Seniors Today, Dr. Das. How have you been?
Good evening, Mr. Maheshwari. Thank you so much for inviting me to talk on this forum. As I'm actually very excited today because it's a very relevant topic, I would say. So,
yeah, but before I want to speak, before I request you to make a presentation on the topic, tell me something. This whole tribe of general physicians, the family doctor,
right,
has virtually vanished, and this is something which I have raised to various people who are internal medicine specialists who have come here. For instance, I have not had a family doctor, so to say, for a while. I have a friend who is into emergency medicine, etc., whom I consult for whatever, and I've been doing that for the last 10 odd years. So is that something that you feel has vanished, the tribe of general physicians, and that has put pressure on people like you who are working with hospitals?
That's actually a great question. Definitely, it's a trend. The whole tribe of GPs and the family doctor, family physician tribe has reduced. However, there are pros and cons to it. I mean, the reason why it's happened is, number one, super speciality is now a given. If you're a doctor, an MBBS or even an MD is not good enough nowadays. So super specialty is sort of a given. That is one. And secondly, all of the information out there on the internet, I think in patients' mind, to an extent, it sort of substitutes the GP. I already know where I have to go, so why should I go to a GP? So
you refer to Dr. Google, huh?
Yes, absolutely. So I think that is the trend more than anything. Yes, I have noticed it. However, that being said, I still have seen that certain GPs in certain, I wouldn't say smaller areas within cities are still very, very, very much reliant on their GP. They will not go to a specialist without going to their GP first. So it's a mixed population, to be honest.
And one more question before I request you to make the presentation is, you've practiced both in Bangalore as well as Bengaluru and Pune. Tell me more about how are both cities and which one do you prefer more? Which one has better healthcare? Let me put it this way.
Okay, it's a very difficult question to answer. Actually, very much like the weather in both the cities, the healthcare is quite comparable, I would say. Maybe in terms of numbers, Bangalore would obviously be larger, and also in the number of seniors. I have noticed that Bengaluru, that population, at least coming into an emergency department, has been higher. However, in Pune, one thing that I've noticed, a very specific thing, is that everyone's very organized and very aware of what's happening, especially the seniors. I mean, they know exactly what they expect from the consultation.
I must tell you, it's not a great joke to put, but at least you can reach the hospital on time in Pune. In Bengaluru, you can get stuck in traffic, right?
No, but Pune is following suit very soon. It's going to be
following soon. So let's get to the topic that we've requested you to speak on. And those of you who have questions, remember we invited Dr. Nayantara Das to speak about common illnesses in seniors and when to consult a specialist. So as she makes the presentation, please go through it and put in your question. As always, mention your age, and your gender so that she could give a more considered reply. Thank you, and over to you.
Thank you, Mr. Maheshwari. Very, very good evening to everyone who's joined the webinar today. So I'll be speaking on a topic that honestly, it's quite close to my heart because this is something that I've noticed in my practice. A lot of misinformation, a lot of misconceptions out there. So I hope to clear some of your doubts and give you some important information today. So we'll be talking about some common illnesses and when to go to the doctor. So first of all, aging is a disease. It is a myth. It is a misconception. That is not true. The only truth is that aging affects the manifestation of certain diseases as well as your recovery. However, aging in itself is not a disease, and neither is it an indicator that you will deteriorate no matter what. That is a misconception, and that needs to be taken out of your mind. So that being said, aging, as the years progress, as the body gets older, it has certain changes, subtle changes in every system of the body. As you can see depicted here, I won't go into details, but right from your central nervous system, your lungs, your heart, your endocrine, that is your hormonal system, your kidneys, your gastrointestinal system, as well as your bones, there are subtle changes that occur with aging, and it progresses with every year. And this isn't a sign that, oh my God, there's nothing that I can do. It's actually just a sign that you need to watch out for certain things, and we need to tweak the way we treat certain things. So there's nothing to be alarmed. We'll just go with what you need to watch out for. So certain special considerations in this age group is, especially what we see is delayed presentations. Very often we see very delayed presentations because there's a lot of tolerance to pain and tolerance to discomfort. So everyone who does end up, at least in the emergency room, ends up very late. Atypical or subtle presentations, not with clear symptoms. Multiple pathologies, as you all know, there may be multiple illnesses going on, diabetes, hypertension, kidney disease, some fractures, all of that going on together. And also difficulties in getting an accurate history for multiple reasons. One is, of course, the elderly above 70, 75, there may be a level of dementia, or we may not be able to get an accurate history, or they may not be able to communicate to us what exactly is going on, which is why we need a very comprehensive evaluation. An evaluation for a younger adult may just involve a history and an examination, whereas in the older age group, it requires a more comprehensive, detailed examination in the form of blood investigations, radiology, etc. So that becomes a little bit tricky. So the $1,000,000 question is, do I need to consult a doctor? So I'll just go through a few of the common conditions. I'm sure you've all faced, some of them at some point in your life. These are the common presentations that, you would go to a doctor with. Falls, any type of heartburn or acidity, abdominal pain, confusion, dizziness, breathlessness, constipation, joint pains, urinary symptoms, reduced appetite, any problems in the vision, and generally feeling unwell or feeling weak. These are very common presentations to any hospital or to any clinic for that matter. I, however, want to just talk about a few presentations, especially in my practice and in an ER that we see very often, that are often neglected or the presentation is delayed. And these things may require very simple treatment to make you go back to, exactly what you were before you fell ill. So I just want to stress on these because a very simple intervention or simple treatment, if diagnosed at the right time, can, restore your health back to your normalcy. So we'll just talk about a few of those. One very important one is falls. Now, falls, very often I see patients all the time coming and telling me, girte to rahenge, we are getting old, we will fall. No, fall is never accepted as just getting old. A fall is always treated as a symptom by a doctor. Now, in falls, both the cause and the effect are important. So the cause of falls are usually multifactorial. It has a combination of, your pre-existing illnesses along with some precipitating or environmental factor that may have led to your fall. And like I said, both the cause as well as the effect of the fall are very important, especially when it comes to somebody who's had recurrent falls in a short period of time, or if they've had a fall and they're not really sure what happened or how it happened. These are give us an idea that we need to investigate it even further. So just go through some of the common causes of falls in the elderly. If you can see, 30.9% is environment or accident related. For example, you tripped over something or you twisted your ankle. It's only 30% of the causes of falls in this age group. The other 70% is related to some organic cause or some condition that has caused the fall, which is so interesting to see actually, because if you go through this list, gait and balance disorders, dizziness, drop attacks, confusion, postural hypotension, which basically means your blood pressure dropping when you stand up from a sitting position, any visual disturbances, syncope, and other reasons. So just saying that the patient has had a fall is never enough. 70% of cases, there is a reason behind the fall that needs to be diagnosed. So that is very important. And moving on to the effects of the falls, I'm just going through the common injuries that occur post the fall for whatever reason. Very commonly, broken, fractured bones are quite common. Hip fractures, spine fractures, and long bone fractures being among the more common ones. Of course, small bruises, cuts here and there are again common. I just want you to take a look at this area. This 2.6%, that is concussion or brain injury, and that is the one that we're a little bit more concerned about. Everything else can be treated with some minor dressings or some observation, ice packs, certain medications. This is something that we need to watch out for and be a little bit more cautious about, which is why I'm just going to go through that. Now, this is a very simple test that clinicians we often use to determine if the cause of the fall was something neurological or something abnormal and not just an environment or a trip and fall. So it's a very simple test, and I believe that it can be done at home also. If anyone in your family, an elderly person does have a fall and he's back to normal and you're unsure whether this was, something to worry about, you can always do this test because it gives you a lot of good idea as to whether you need to, hurry down to the hospital or you have some time. So it's called the get up and go test. You make the person sit on a chair, stand up from the chair, walk 3 meters in a straight line, take a turn, walk 3 meters back, and sit down. What you want to look out for is any unsteadiness or loss of balance or dizziness in any of these steps, while getting up, while walking, while turning, while walking back, while sitting down. If there's any giddiness or unsteadiness, you have to consider a neurological problem that may have caused the fall. And that's not anything to be alarmed about, but it's something that needs to be investigated. So that's, I think, a very simple test that everyone can try to follow at home. Yes, so like I said, I just wanted to go into the concussion and head injury portion because it's a little bit, it's a little tricky to diagnose. Now, see, if someone has a very bad head injury, it's very obvious that their head is injured, they're vomiting, they have a headache, all of that. Anyone would go to the hospital. That is a given. But what happens in the mild cases? I've fallen down at home, I've hit my head, but I'm fine. I have a little bit of a bump on my head, that's it. Why should I go down to the hospital? So in anyone above the age of 60 years, okay, even a very mild injury like a trivial fall at home can cause an injury inside your brain, which what we look out for is bleeding within the brain. So anyone with a mild head injury, we need to keep a very high index of suspicion, and I'll explain to you why. Also, I just wanted to read the first line that I've put here. A study actually found that 82% of people hospitalized with head injury, that is senior citizens hospitalized with head injury, went back to living, went back to independent living, back to their normal functional self when properly treated at the right time. So that misconception that, if I have a head injury at this age, I'm not going to get better, that is completely false. If you're diagnosed at the right time and you're treated in the right way, very, very, very high chances that you'll go back to baseline. So why are we worried about this in this age group? If you look at the diagram on the left, you can see that the brain over here, so imagine this is the brain of a 35, 40-year-old. However, this is the brain of somebody post 65, 70. So this is what we call as cerebral atrophy. Your brain starts to shrink. So the brain mass starts to shrink. However, the skull remains the same. So there's a bit of a gap over here, as you can see that. Now, what this translates into is that if this person gets any kind of intracranial injury or there's a bleeding within the brain, it starts to compress the brain immediately and he will show symptoms and he knows that something is wrong. But in this case, if he bleeds and if anything collects here, this person will not show any symptoms until the bleed has reached this point and compressed the brain. And that is where the problem lies. So anyone with even a mild fall at home hits their head and you feel completely fine, but you're above the age of 65, a very simple test, it takes 30 minutes, not even 30 minutes, it takes about 15 minutes. A CT scan can help you rule out a bleed because your symptoms will not help you. You are not going to present the same way that a younger adult would present. And let me also tell you that I have seen patients who come in with a paralysis because of a bleed, 78, 80, 90 years old even, with a simple surgery, they're back, they've walked out of the hospital completely fine. So it's just a matter of catching it at the right time. So which is why I'm stressing so much on this, that even if a small fall at home, you have hit your head even a little bit, please come down to the hospital, get the scan done. If it's normal, great, you're happy, I'm happy. We all go on with our lives. But if there is any chance that there is any bleeding within the brain, it can be immediately tackled and we can avoid any adverse outcomes. I'll move on. Of course, fractures are very common. I won't go into details of this. Hip fractures, rib fractures, extremity fractures, spine fractures. And like I'd say 70% of these fractures can be managed without surgery. Hip fractures, yes, they do require surgery in most cases. However, other fractures, for example, spine, extremity fractures, rib fractures are all managed. If they're diagnosed at the right time, they can be managed by simple medications, immobilizations, a little bit of physiotherapy, and you can lead a very normal life. So it's just a matter of picking them up at the right time. Now, prevention of falls, of course, it's a multifactorial thing. Anyone who has a tendency to fall, any gait or imbalance, vision problems, there are multiple things that we need to take into consideration. And physiotherapy is the mainstay of that. If anyone has any gait or imbalance issues, please make sure that the physiotherapy is happening, because that is the one thing that will prevent worsening and prevent complications due to falls. Okay, now another symptom that we see very often, especially in the ED, is delirium or acute confusion. That's what we call it. Now, what is this? Basically, it's a state of confusion. Now, anything that my patient is acting off, my patient prefers to sleep, my patient is not talking to me properly, my patient is talking irrelevant stuff. All of this comes under acute confusion. And trust me, it's a very common thing in the senior citizen, that age group. And very often it can be missed if a routine cognitive testing isn't done. Very often it's just written off as, oh, it's just old age related. But it's something that, you know, if it's happened in over a short period of time, we need to look into it. Maybe a simple cause that can be corrected and the patient will be back to normal. So what is delirium? You need to ask the following questions. Was there any change in consciousness? Is the patient semi-conscious? Is the patient preferring to sleep? Is there a reduced ability to focus or sustain attention on one thing? Is there any problem in the language, memory, or orientation to time and place? Have these symptoms, this is very important, developed over a short period of time, hours to days? And is there a fluctuation? In the morning, he's okay. In the evening, not okay. Any of these things, you need to think, okay, this seems like a delirium. I need to get it investigated. And why is it important to get it investigated? Because the causes are sometimes very simple and easily correctable. So a very common cause of delirium, one of the foremost causes is infection. And I really want to talk about this because, see, when you think of infection, anybody who thinks of infection thinks, okay, I will have a fever, I will have pain, I will have some symptoms. If I have a urine infection, I will have urine symptoms. If I have a chest infection, I'll have chest symptoms. However, in the senior population, the response to pain, the response to pyrexia, that is fever, is blunted. So if I have a chest infection, I might have a fever. However, somebody who is 75 and who has a chest infection may not even have a fever. the only symptom that they may present with is confusion, which is what makes it tricky. So any kind of confusion, if we see any patient who comes in with a little bit of a confused or, talking something irrelevant, we first think, okay, we need to rule out an infection and we need to investigate. The only way to do it is through investigating it. We need to send some blood tests. We may need to do a urine panel. We may need to do an X-ray just to find out where that infection is hiding, because their symptoms will never be typical. And once we catch the infection, all the patient needs is antibiotics, and we'll be back to baseline. Another very simple cause of and very easily detectable cause is metabolic disturbances. For example, your sodium levels going up or down, your sugar levels being down, any calcium going up and down, any renal impairment. These are detected through simple blood test of electrolytes. And if detected, they can be corrected. It might be something so simple as adding salt in your diet, and the confusion reduces. So that's the importance of just, catching these things at the right time. Another thing is, of course, toxic insults, certain drugs, either in larger doses than they should be, or interaction of two drugs causing the levels of that drug to be high in the blood for longer. These can also lead to confusion or delirium. Of course, we have to think of neurological conditions like stroke, any bleeding within the brain, like a subdural hematoma, an infection in the brain, all of these, again, all treatable causes. And last but not the least, hypoxia. Something that we've seen very often in COVID. Hypoxia is basically a lack of oxygen in your blood. A lack of oxygen going to your brain will lead you to a lower or a depressed neurological status. So that may present in any possible way. It may make you irritable. It may make you drowsy. It may make you either end of the spectrum. And we've seen so much of this in COVID. So that's another thing that we do consider. And again, easily detectable by putting a saturation monitor on your finger. That's it. Okay, so that is the importance of this type of presentation. Now, how do we treat it? Things that we obviously, like I mentioned, once we know the cause, we treat the underlying cause. If it's an infection, we may, control the source of that infection, start on antibiotics. If it's a metabolic cause, we just correct that. But apart from treating the cause, the other things are very important. For example, we need to optimize the environment because the patient, and this is not only for doctors, it's also for the caretakers and the caregivers of patients. You need to, in such patients, need to keep their environment a little bit cool, calm, and keep them comfortable, because they aren't really able to fend for themselves in that moment. Good nursing care, again, plays a huge role in such patients until they get better. And another actually a very bad practice of using sedatives in patients who are in a confused state or agitated. Very often, we write it off as, oh no, he's not been able to sleep, or so, we'll give him a light sedative at night. What happens is, doing that without consulting a doctor is a little bit tricky, because it may lead to hiding certain symptoms that we need to see in order to diagnose another condition. So use use sedatives very carefully in patients with a confusion or patients who are agitated. Please do not do it without consulting a doctor first. Another very common presentation, I'm sure you'll all agree, is abdominal pain, acidity, heartburn, uneasiness in the stomach, uneasiness in the chest. It's a very, very common symptom in all age groups, to be honest, but it's even more relevant in seniors. I'll come to why. Again, like I mentioned, perception of pain is blunted in as age progresses. So what I might consider severe pain, somebody else might consider nothing. So that's where the problem lies, because the pathology may still be serious. So any acute abdominal pain, that is any pain that has started suddenly, is whether it's mild or severe, and it is persistent for a couple of days or couple of hours without any relief, is something that needs to be investigated. So these symptoms may be like very vague, you may write it off as, oh, acidity or indigestion or food poisoning. But these things, it's a little tricky to just write them off without a careful evaluation because of the possibility of complications. So I'll come to the possible complications. It's a very famous saying amongst surgeons that the abdomen is a Pandora's box, because there's so many organs in there that you don't know what is causing your pain and what is going to be a problem. And that's why we're very careful. In any age group, anybody who comes with an abdominal pain, we're a little bit careful because we want to make sure we're looking at the right organ and treating the right organ. Additionally, any pathology in the chest or the heart can also cause an abdominal pain. So that makes it even more confusing. So some common issues I'll talk to you, especially in this age group, are cholecystitis, which is inflammation of the gallbladder, obstruction of the bowel, which basically means that your bowel movements aren't progressing as they should, either because of an actual physical obstruction or because the actual movement or motility has reduced. Then, of course, appendicitis, ulcers, pancreatitis, any vascular cause, that means that your blood vessels supplying your abdominal organs may have a problem. And urinary infections, again, very common in this age group. This could be, any one of these could be a cause for your abdominal pain. And again, it's very simple. All you need to do is get a simple ultrasound. And if it's normal, like I said, you're happy, I'm happy, we all go back to our lives. However, if we catch any one of these things, they can be treated on time and you can go back to living your normal life. But don't ever ignore an abdominal pain, especially if it's of an acute onset. Now, coming to one of the very important things, again, because I spoke about abdominal pain, in this age group, only about 60% of them will actually present with chest pain in a heart attack. 40%, which is such a large number, will present very atypically. The symptoms may not be related to your chest at all. You may have an abdominal pain, you may feel dizzy, you may have confusion, you may only be sweating, you may have some sort of breathing issue, but you won't have chest pain, and it turns out to be a heart attack. So this is not intended to scare you, but it's intended to tell you that a very simple investigation like an ECG that takes 5 minutes and maybe 500 rupees, maybe even less, that can completely rule out a serious condition in this age group. So it shouldn't be taken lightly, which is why any sort of heartburn or any feeling of uneasiness, something that's abnormal or persistent upper abdominal pain, is something that needs to be evaluated. And it's a very simple test that can be evaluated and ruled out. And I'd also like to mention the last line that I've mentioned in my slide over here, that the early diagnosis and management of heart attacks with intervention at the right time has shown excellent outcomes irrespective of the age. So if it's a 40-year-old or if it's a 90-year-old, if a heart attack is caught and treated in time, you can go back to living your life just like you would if you were younger. Now, one of the last things that I want to cover actually in my talk today, and I think I've saved the most important for last, is polypharmacy. I think it's pretty self-explanatory what it means. It's basically the use of multiple medications. We usually say more than 5 a day, to keep it simple, or the administration of more medications than actually indicated. Now, why does polypharmacy happen? It's very obvious. One is this age group, multiple illnesses, you'll be on antihypertensive, lack of patient education. And this comes from, from both sides. A lot of times doctors are not able to explain in depth or to the patient's satisfaction why the following medications are being started. And secondly, the patients themselves are not probably informed enough about what this medication does and why it's being taken. Most importantly would be a lack of a review. Medications being taken, the same medications being taken, and 5-6 of them being taken for years together without a review. That is a huge contributor to polypharmacy and its related issues. Then, of course, attendance at multiple specialist clinics, your second opinion, third opinion, fourth opinion. That also leads to multiple medications being started, stopped. And the most important is over-the-counter medication. That's another contributor to all of the adverse drug reactions that we see very often. Now, why is polypharmacy such a problem? So in this age group, as your age progresses, your ability to remove drugs from your system reduces. So the level of drugs builds up in your system and stays in your system much longer. So the chances of it causing an adverse reaction are much higher as you grow older. And of course, multiple drugs, drug-drug interactions, and something known as the prescribing cascade, which is actually very interesting. Very often somebody started on a new medication, say, and they develop some symptom, they develop some confusion or some dizziness. They go to a doctor and the doctor thinks it's a new symptom. They prescribe something for that symptom and becomes a vicious cycle. So a lack of information as to what the possible drug-drug interactions and their effects could be in the patient leads to more and more prescribing, and that leads to this prescribing cascade, which can be very dangerous. So for all those of you listening who are on multiple medications, 4 or 5 medications for different illnesses, no matter what they are, please look out for any, these are very common symptoms that I've put out there. Look out for any of these symptoms: confusion, depression, dizziness, drowsiness, recurrent falls, any urinary or fecal incontinence, insomnia, a coordination loss, any dehydration, sudden weight loss. Any of these are you feel, especially if there has been a recent addition of a medication or a recent change in prescription, and you start developing any of these symptoms, you need to be vigilant and report it as soon as possible. So how do we prevent this? Of course, doctors advise a monthly review for those who are taking more than 5 medications. See, everyone responds to every medication differently, and some of them may need to be weaned off, some of them may need to be increased. A monthly review should be done, ideally. And of course, compliance to medication, and very importantly, transparency. If you have taken any over-the-counter medication, if you've taken an alternative therapy, if you've stopped the medication or missed a dose, please be very clear and transparent with your doctor so that they can make the right decision as to how to review your medication regimen. And like I said, look out for those symptoms. If any of those symptoms are, you notice any of those symptoms, please report it immediately to your doctor, and please avoid over-the-counter medication. I've just listed down a couple of the main culprits of adverse drug reactions in seniors. Your NSAIDs, which are painkillers, those you need to watch out for. Then your antihypertensives, like your ACE inhibitors, beta blockers, diuretics, all of these are things that you need to look out for. Again, blood thinners like warfarin can have interactions. Antidepressants, sedatives, all of these can have drug-drug interactions. So if you have been recently started on this, or the dose has been changed and you start to develop any symptoms, please report it immediately. And if I have any physicians watching this webinar, this is a very useful tool for us to sort of review medication and give us a systematic way to go through all of the medication and decide what we can maybe omit or add in order to avoid the adverse drug reactions related to polypharmacy. So it's the ARMOR tool: assess, review, minimize, optimize, and reassess monthly. And last but not the least, to all my friends who are graduates and postgraduates of any of these universities, please be very cautious. There is so much misinformation out there. And what we often see is that it gives you either a false sense of panic or a false sense of calm. And both can be very, very dangerous. So please, 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 before you follow anything that has come to you as a WhatsApp forward or you've read in a random article on Google, please consult your doctor, consult your physician, take a review, and then decide to stop or add something to your medication list. Thank you so much. And I'd love to take your questions if there are any.
Thank you very, very much, Dr. Das. This is a very good and detailed presentation. So, as you were making this presentation, I just pulled out my drawer and I found something which I keep with me: pan 40, Imodium, Omniflam. I'm not going to show you how many I've had from you, but clearly the problem is coming over here is that do we take over-the-counter medicines or not? There are sometimes when we're not able to consult or connect with the doctor, especially on weekends. are over-the-counter drugs an absolute no-no? This is an anonymous attendee who's asked this question, who's 65-year-old.
Okay, so that's actually a great question. See, if specifically to people above the age of 65, even regular medications like a pantoprazole or an Imodium may cause effects that would not be caused in somebody who's younger. Okay, just because of basic metabolism. That drug is going to be in your system longer. So what would possibly be in my system for 4 hours is going to be in somebody else's system for 12 hours. So there is no way to predict how it would interact. I think in this day and age, there is always an online consult option, and all of those options are always there to get in touch with your doctor regarding over-the-counter medications. However, I would still say that if it's an antacid, like pantoprazole you mentioned, I'd say, all right, go ahead. Please, please, please avoid painkillers. That is something that should be avoided completely. No over-the-counter painkillers, as well as Imodium. Imodium, please throw that strip away.
Thank you. We have two people who have complimented you, Satish Kalya and Mr. Balafraj Nagashetty, very well explained. We have a question from Mr. Nayantara Manava, who is an 83-year-old. He says, right. Problems I face are, as mentioned in polypharmacy, mainly specialist communication. After Corona period, marketing people are running corporate hospitals. I know it's a tricky question for you to answer, but
no, it's actually very relevant. It's a very relevant thing. That's why I put it in my slides. It's a two-way street. Specialists very often, I mean, they have roaring OPDs, don't have the time to go through all of the prescription, all of the prescribed drugs. But we as physicians, as a community of doctors, we need to make that effort to be a little bit more careful when it comes to somebody with multiple prescriptions. We need to have that communication. For example, if I am treating your diabetes, I need to be talking to your cardiologist regarding the heart medications, and at least the medications that have very high chance of interaction. So that does need to happen. So, and yes, I agree that post-COVID, nobody, maybe that interaction and that communication has reduced.
In fact, doctor, there's a question which has come in. He says, I am scared of visiting a doctor now because I don't know who the other patients are at the clinic. And you're talking about emergencies and casualties. They could be people with all sorts of illnesses. So how can one go and be sure that you're not catching an infection?
Okay. So in terms of infections, right, that patients come with, it's very, very unlikely that these infections are airborne, right? These are all either droplet infections or fomites that we call touching, that are transmitted by touching of infected surfaces. So by taking few basic precautions, you can avoid infection. Irrespective of what patient has come before you. If you wear a mask, if you do not touch any of the surfaces around you, and even if you do touch, if you sanitize an adequate hand rub with a sanitizer and your mask is on, very, very low risk of catching any infection. So if
would you advise masking up all the time? Even now?
If you're going to a hospital, you should mask up.
And what about otherwise in general, life in general? Should seniors be masking up?
No, I don't think that it's indicated anymore. If you are unwell, if someone in the house is unwell, has any upper respiratory type of symptoms, any cough, cold, it's a good practice either way to wear a mask. Apart from that, I don't believe that you should be wearing a mask if you're just going out somewhere. Not at all. But in a hospital, it's a good practice to wear a mask.
Thank you. We have a question from Mr. Lakshminarayan from Bengaluru, who's 68 years young. He says he walks on an average 5 to 7 kilometers. And twice in the last 3 years, he has tripped and fallen. Nothing on the head, only knees and elbows. This fall does not get in the category that you mentioned, I suppose. In such situations, what kind of consulting needs to be done?
Okay. So if the fall did not, he's clearly fallen on his knees and his hands, and he's got maybe minor injuries. If there is no obvious restricted movement, he's able to walk after that. If he's able to move all of those joints, that's okay. he doesn't need to go ahead and consult a doctor. But even if there is a mild swelling, persistent pain, it's bothering you, or you're not able to go back to your normal, your baseline, that would be walking 6 kilometers, anything is troubling you, you need to just go and get an X-ray. An X-ray is a simple 5-minute thing to just rule out a small fracture. That's it.
Right. There's a question from Mr. Lakshman once again, who says he's moved his widowed mom in her mid-80s to Bengaluru from Mumbai. He's found it quite odd that local doctors here do not make home visits. It was tough to take his mother to a clinic, but the GPs here just refuse to visit. It's an irony that people come home for pedicure and massage, but why not to consult? That gets so easily done in movies where we see Nazir Hussain has a Dr. Satyan Kapoor in Kati Patan, who visits as and when needed. So, doctor, this is a question which is there, where I raised this issue about general physicians and the lack of them available in big cities like Mumbai. They'll rather give the clinics for ATMs, etc., but not for the clinic. So, is this a problem that we're facing, and what should people like Mr. Lakshman do?
So, see, again, like I mentioned, the online consultation era is here. So I do not think that it will be impossible to find any doctor. For example, your doctor may not be available. Every doctor needs his day off. He may not be available on a Sunday to answer your problems. But your physician would prefer you spoke to another physician before starting a treatment, then started yourself. So even if you are able to get in touch with another physician over an online consult, anything that you can do, as long as it's a physician, it would be a better alternative than starting or stopping a treatment on your own or taking something over the counter. That is what I believe. Of course, home visits, that's a very good point. I think that yes, it was quite a fad at some point, home visits amongst doctors. Now it has reduced. Again, I think it's a post-COVID thing that, even doctors are sort of trying to avoid anything that would lead to an infection from their side. I do believe that maybe that trend is going to start up again. It'll just take a few years.
Thank you. We have a question from Mr. Brij Duggal, who says his wife takes sleeping pills 3 to 4 times in a week, after which she cannot sleep, without which perhaps she's not. Is it harmful? He asks. She is 75.
Okay. See, again, I would need to know what other medication she's on and what other comorbid illnesses she has. But if she's become dependent on these medications, she needs to be, again, a review needs to be done. Maybe that medication isn't working for her. Maybe there's another stressor or another cause for her insomnia that can be treated easier. So anyone who starts to develop a tolerance to sedatives and who says, I cannot sleep without it, it's something that needs to be investigated a little further, especially if there are other medications going on. Suppose there aren't any CNS depressing, that depress your neurological function medications going on apart from this, then I don't see any harm in taking a sedative for a couple of times a week. However, if there are other medications going on and you're developing a tolerance, it's something that needs to be cut down on.
Right. Thank you. This is a question from Katie Dadanchi, who says, Doctor, I'm 72, and in a routine blood test, my B12 level was 83. What is the reason for this low level, and how can this be increased? She has another question. Is my husband, who's 77, has constipation? What will help him ease the situation? And taking regular Cremafin, is it safe? So let's look at the first question first about her B12 level, which was 83.
B12 levels, I mean, especially if you're a vegetarian, it's quite common. We do see low B12 levels in vegetarians, and we tend to, it's again easily correctable. There are medications, you can start taking supplements. Initially with a low B12, we do advise IM injections, followed by regular supplements, and that comes back up. And you need to correct it because it does have effects later on your general. You'll start to feel tired. It affects your nerve function in the long run. So it needs to be corrected. Other reasons are also problems in the gut, like, if you're vitamins and minerals are not being absorbed the right way from your gut. Those are also reasons for your B12 being low. Again, it requires a little bit of evaluation. If you're a vegetarian and your B12 is low, we'll probably correct it and then take it forward from there. If you're not a vegetarian, your B12 is low, we need to investigate it further. It'll be done. If you go to a GP, they'll let you know what series of tests need to be done for that.
Thank you. Katie Davanchi is a Kusrobag Parsi, so I'm unlikely that she's a vegetarian. Okay, her husband who's 77, has constipation. What will help? And the question is, what will help him ease the situation? And is taking regular Clemifene safe?
Okay. Again, very good. I was expecting this question actually. This age group, I've noticed, is the most distressing symptom for them, constipation. And I understand it's a very distressing symptom. However, like I mentioned, I think in my first few slides, right, that aging has an effect on all parts of the body. So the effect that it has on your GI system is that it reduces the motility of your intestine. So it reduces the movement downwards of anything that is within your intestine. So constipation is very common for that reason. That is the main reason why constipation is common. And what also, secondly, the ability to digest all types of food starts to reduce with age. So if you do not change or tailor your diet according to your age at the right time, you will start to face constipation. So as your age is progressing, you need to start having lighter meals, smaller meals, high fiber diets, so that you can reduce that incidence of constipation. And should it occur, first thing is you should not be alarmed. Very often I have patients coming to me and saying that, will I die? I have constipation. I'm not gone for 2 days, will I die? So that fear needs to go. So you will not die from having constipation. You can use a light laxative, take a high fiber diet, give it some time. A constipation may be relieved in a younger adult within a day. It may take 3 days for an older person, and that is expected. That is normal. It's nothing to be alarmed about. I think dietary changes are the only way to go. In terms of Clemifene is okay. It depends on how often you're taking it. If you're taking it daily forever, maybe you should start to reduce it, because it will just ultimately lead to local area issues.
Doctor, I know we've crossed the time of 5:45, which is our own self-defined Lakshman Rekha. But if you don't mind, can I take a few more questions?
Of course, of course.
Okay, so this is by Mr. Sumerchand Jain, who's 80. And his question is, I feel giddiness quite often during this 1 or 2 minutes. After that period, I become okay. I've got an ECG done. It's all okay. Please suggest how to handle, and he doesn't have any heart problems.
Okay. So giddiness again is one of those symptoms that can be caused because of multiple things. A very common thing that we've seen in this age group is that postural hypotension, which I spoke about. For example, a sudden change in your movement leads to a sudden drop in blood pressure. As you grow older, your compensatory mechanisms that are already in place for your body. For example, if I get up suddenly from a sitting position, my BP will fall. But the compensatory mechanisms in place will not allow me to feel dizzy. It will push my blood up faster. However, as you age, that mechanism starts to slow down, which is why any sudden change in position may cause that momentary dizziness. However, if you're back to baseline, you remember the event and you're able to go back to your normal duties, everything, your normal activities, and your cardiac evaluation is normal, I don't think you need to worry about it.
Right. We have a question from Mr. Brijendra Kumar, who's 78 from Mumbai. He has 2 questions. I suffer from constipation. I'm vegetarian and take simple food. How to improve my digestive system? That's one question. And the second question actually has been asked by various people. How does one keep old age related diseases like Alzheimer's, dementia, or Parkinson's, which he says he luckily doesn't have any at all. But the first question is important. How, he's a vegetarian and he takes simple food and he wants to know how he can improve his digestive system.
Okay, so like I mentioned, it's also rather than the actual simple food, it is smaller quantities, multiple smaller meals, as well as high fiber. Fiber is the most important. The fiber, the higher your fiber is in the diet, the easier you will be able to digest all kinds of food. It's not just about eating simple, non-spicy food. Very often people say that, I'm not eating any spicy food. I'm not eating outside. Why am I still constipated? Maybe your fiber levels are not up to the mark.
Thanks. We have a question from Mr. Arvind Gharat, who's 69. His question is, any adverse effect of Thyrocure over a long period and interaction with cholesterol drugs?
So as far as I know, thyroid, that is your thyroxine, does not have a direct interaction with cholesterol drugs, that is statins. It can be taken safely together. Again, I would need to know the dose exactly for that, because it depends on what dose of Thyrocure is being taken. But I've not seen a routine interaction between the two, no.
Doctor, we have a question from Trilokinath Dubey, who's 69. So Dubey's question is, he has liver fibrosis. Which painkiller is safer for people with problems?
Sorry, your voice broken in between.
Which painkiller is safer for people with liver problems?
Okay, so in somebody with liver problems, like a fibrosis, what we would suggest is usually paracetamol in higher doses is avoided, as well as the other painkillers, what we call the NSAIDs, are avoided. So we prefer to give small dose of opioids. So one that does come in a tablet form is tramadol. So tramadol is a tablet that can be used as a painkiller for patients who have any liver-related issues. Again, it needs to be prescribed by a physician.
We have so many questions which I'm not going to be able to take. There's one question which is something which you mentioned again from Mr. Lakshmi, but it's an important question. Is paracetamol not to be taken without consulting a doctor?
Okay, again, a very good question actually. So paracetamol is the kind of drug that is very safe, provided it's taken in the right dose. Toxicity of paracetamol, if taken even 1 milligram above the toxic dose, is very severe. So in the span of 24 hours, we say the toxic dose, or what, the dose beyond which you should not take, is 4 grams. So what we normally take would be our Dolo 650. If we take our Dolo 650 even 4 times in the day with a 6-hour gap, that should be all right. But if we take a 1 gram paracetamol with a 6-hour gap 4 times a day, you've already reached that borderline where you will start showing effects on the liver. That being said, anyone with even a mild liver disease, the whole scenario changes, because even lower doses of paracetamol can be toxic.
Doctor, tell me, what is the risk of getting fake drugs? Because paracetamol has you mentioned a few drugs, but is there a risk of getting a fake Dolo 650?
That's quite a difficult question to answer. I mean, that risk always exists, and it's something that I feel.
Is it better to have? Is it better to buy a medicine from a chemist which is attached to a hospital? Is that safer if one does that?
Yes, I would say that it is safer because it's more closely regulated.
Right. Doctor, one more question, because this person asked quite some time back. I missed. This is Mr. Bharat Mehta, who's 66. He takes heart medicines in the last 2.5 years, uric acid medicines in the last 6 months, skin fungus medicines in the last 3 months. Please let me know the side effects of the same in daily life. Okay.
So heart medications, uric acid medications, and skin-related medications, right?
Right?
Okay. So heart medications, again, it depends on what the heart medications are very varied. But I'm assuming that heart medications usually are related to reducing fluid accumulation. So they're very often diuretics which extract fluid. So that again can cause what I mentioned, your dizziness, your syncope, your postural hypotension. All of those things can be caused by many heart medications. Again, heart medications could also mean blood thinners. So blood thinners, again, you need to be very careful. If you're on one blood thinner, all right, usually if you're just on an aspirin, it won't cause much problem for you. But if you're on 2 blood thinners, very often people are on clopidogrel or ticagrel or additionally to ecosprin. Of course, there is a high risk of bleeding in such cases. A small wound may bleed longer. And it's not something to be alarmed about. It's just that you require to keep pressure on it longer. Or if you notice any bleeding, you need to be a little bit more vigilant. So heart-related medications, yes, they have these particular side effects. Antifungal, skin-related medication and uric acid medication, I wouldn't say that there are any very significant side effects that we could talk about at the moment. But yeah, again, GI side effects, constipation-related issues, gastritis issues are there with all medications.
Thank you very much. Thank you very much for your amazing presentation. And really taking, we've crossed our time limit. It's 5:55 now. I think we still have questions to answer, and we'll perhaps invite you once again and request you to respond to some of the questions that are there. So sorry, those of you who have asked questions, Dr. Siddhi Bora, Mr. Tirunokinaji, Ajay Vishnu, and who's asked how often do you recommend elders to thank you very much, Kashi Vishwanathan, Ajay Vishnu, again, Kaushpendra Singh. I'm sorry I'm not able to take all the questions because we've just run out of time. But thank you very much once again, Dr. Nayantara, for taking this, for taking time out and for this amazing presentation. I'm sure people have mentioned that they've enjoyed the presentation, and I'm sure they'll benefit a lot. As always, this presentation, this edited video will be there on our website on Monday evening, along with the takeaways written by a medical doctor who writes the takeaways and who will be there on the Seniors Today website on Monday evening. So do look out for that, as well as the video. That those of you who may have missed the presentation or something that's written in the presentation, you can always look at that. We will be back once again next Saturday at 5 p.m. with the Health Live at Seniors Today. And those of you who would like to pre-register, you can do that. You know, we offer pre-registration for our various sessions. Our producer is having a bit of disconnectivity, so I want to put the link on the chat window. But if you are interested, you can just write to us at edtor@seniorstoday.in. Remember, we've completed 4 years now. Our anniversary issue, our 4th anniversary issue, is there on the website, and you can go through it over there. It's free of cost. Thank you very much once again, Dr. Das, for taking time out and for advising our readers and viewers here. We will be back once again next Saturday at 5.
Thank you so much.
Subscribe now and press the bell icon. Never miss an update.